Now we're going to talk about traumatic brain injuries. Um, People that are at risk include males are at risk because they do stupid stuff, and then people that drink alcohol and do drugs and then do stupid stuff. Older adults, they're going to be at risk because they take a lot of medications that could make them drowsy or dizzy, and they also can be all blood thinners, so it makes them at risk, and they're at risk for falls to begin with. People with psychiatric or cognitive disorders are more at risk, and those that engage in contact sports, so sports injury, they're going to be high risk for TBI. The most common cause of TBI is falls, them being struck by an object or being involved in a motor vehicle accident. So traumatic brain patients, injury patients are going to need cervical spine x-rays, possibly an MRI, CAT scan. They're going to have a cervical collar when they come into the ED, which cannot be removed until the provider says it can be removed, and that's to protect their spinal cord. Anytime you have a head injury, you check for spinal cord injury. Anytime you have spinal cord injury, you check for head injury. So an open TBI may appear at your ED, and they're going to be an infection risk. So we would watch them closely for signs of infection and septic shock. With a closed traumatic brain injury, we worry about brain herniation, which occurs because there's only so much space in the skull, and the skull is rigid, so the skull cannot move. So there's only enough room for the brain in there. Now, if you have a TBI and somebody has a hematoma or you have a brain tumor, the brain's got nowhere to go inside the skull. So the brain may start herniating, meaning it may start shifting, okay? And this is going to cause increased intracranial pressure inside the skull. There's different levels of TBI, and the first one is the most mild, so it's a mild TBI. It's also known as a concussion. Patients with a mild TBI or a concussion, there's usually a change in neurological function, but no brain damage associated with it. Usually resolves in 72 hours. They're treated and treated based on their signs and symptoms when they present, usually to the ED. They're going to need lots of sleep and rest, okay, and a gradual return to their ADLs. Now, the Glasgow Coma Scale will be scored as 13 to 15, and I had gone over the Glasgow Coma Scale in the A&P and assessment lecture, okay? They may or may not lose consciousness if they have a mild TBA. They are definitely going to complain about headache or pressure. They may have amnesia, they may not. They may lose consciousness, they may not. They may complain of dizziness, nausea and vomiting, confusion, and they'll be sluggish. Another concussion within 10 days could increase the risk of brain problems, and they may have problems with memory and attention for up to 4 weeks. So a contusion means there's a part of the brain is bruised, okay? There's going to be a period of unconsciousness. The patient will have stupor, be confused, so watch out for increased intracranial pressure. A basilar skull fraction can occur during a TBI, and this is not picked up on a CAT scan or an MRI, so you have to use your nursing spidey sense. Most patients, all patients that have a TBI, they come to the ED, they're going to get a non-contrast brain CAT scan. The reason they don't use contrast is because contrast shows up as white on the CAT scan result, and so does blood. So they do non-contrast to look for a hemorrhage first. But anyways, back to basilar skull fracture. So it's diagnosed by CSF leakage through the nose and the ears. The patient may have bloody or clear drainage coming out of the nose or the ears. So if it's coming out of the ears, it's called otorrhea. If it's coming out of the nose, it's called rhinorrhea. It could be bloody or clear, and you need to do a halo test. So the basilar skull fracture is fractures on the baseline of the skull. Okay, so remember that, and I'm going to show you what it looks like in a minute. These are pretty obvious signs of basilar skull fracture. Raccoon eyes and then bruising behind the ears is called battle sign. So those are cardinal signs too. With halo sign, you take the fluid that's leaking from either the nose or the ear and you put it onto a white gauze pad, and in a few minutes the blood collects into the middle of the center, and then there's like concentric rings of cerebral spinal fluid. So that's how you tell. Another thing you can do is a glucose dipstick to see if there's glucose in it, because your mucus doesn't have glucose, but your cerebral spinal fluid most definitely does. Now the preferred method is always going to be halo sign first, but I'm just telling you the other option is testing it for glucose. If you have somebody with a basilar skull fracture, you want to manage the leakage of CSF, cerebral spinal fluid. So head of bed needs to be 30, no pillow, because you don't want the neck to flex, okay? Because if you have any flexion, like with the head and neck, the patient it could increase intracranial pressure. So you want the head and neck in proper alignment. So the head of bed 30 and the head and neck just straight, not flexed. Okay, so that means so the cerebral spinal fluid can drain from the head. You may put a mustache dressing or an ear dressing, keep it sterile. No blowing nose, no picking nose. You're going to have to teach them that. No coughing or sneezing. Never plug up the ear or nose. No hip flexion. If they have a fever, you need to be very diligent in treating it, because temperature increases intracranial pressure. So you have to treat that quickly. Everybody that is at risk for increased intracranial pressure needs a stool softener so they don't strain when having a bowel movement. And they need pain control, because that may increase intracranial pressure as well. All right, next we're going to talk about hematomas. They can result from traumatic brain injuries as well. An epidural hematoma typically occurs there's an injury to the temporal region of the head, okay? And it's usually due to damage to the middle meningeal artery, and it's arterial bleeding, so you have to act really quick to recognize this, because arterial bleeding is fast bleeding, right? They could really bleed out. The hallmark sign is the patient will be unconscious. They'll have a lucid interval, meaning they'll regain consciousness, and then they'll be unconscious again, and usually it's downhill from there. So you need to be able to recognize it so the patient can go to the OR and get it evacuated. Okay, in this slide, we're going to compare epidural bleeding with subdural and intracerebral, because these three types of bleeds can happen during a traumatic brain injury. So epidural, we talked about earlier, it's arterial bleeding, so it's fast bleeding. And so we need to recognize it early so we can get the patient to a CAT scan and then to the ED. Okay, I'm not the ED, the OR. So with epidural, the cardinal sign is first the patient's unconscious, they become lucid, then they become unconscious again. So there's a rapid decline in LOC after that lucid interval. They'll have nuchal rigidity, which means stiff neck. And the reason is anytime blood is in the brain in a space it's not supposed to be in the cerebral spinal fluid, it irritates the cerebral spinal fluid, and they have what's called meningeal signs, such as stiff neck, nuchal rigidity, seizures. They're going to have a headache because they have a traumatic brain injury, nausea and vomiting. With epidural, they could have periorbital ecchymosis, because remember, it's on the temporal side of the head that they have the TBI, and usually it's from a bleed of the middle meningeal artery. All right, they will have a blown pupil or a dilated pupil on the ipsilateral side. So anybody with a brain bleed, if they have a brain bleed, the pupil can become dilated because the brain is pressing on cranial nerve 3 on the same side, ipsilateral side of the injury. Okay? They could have contralateral hemiplegia, so contralateral weakness. So watch out for that. Subdural hematoma is venous bleeding, so it's a little less worrisome, but still, we still worry about it, okay? It can be acute to subacute to chronic. So chronic, it can take like up to 2 months before somebody starts having symptoms from a subdural brain bleed. So I took care of a patient once, and I think it was February. She was out shoveling snow. She fell. She hit her head. Forgot all about it, and I think it was about May she came into our ICU with the subdural. Okay, so oftentimes they have to think back to when they fell. That's chronic. Subacute, the symptoms would occur probably about a couple weeks after, and then acute would happen right away. So people that drink a lot of alcohol and older adults are going to be really at risk. And the reason is that alcohol shrinks your brain, and getting older shrinks your brain. So there's more space in between the skull and the dura mater. So it's a place where slow bleeding could collect over a long period of time. So again, they could have a dilated ipsilateral pupil. They could have contralateral weakness. So you'll be looking for that. They'll complain of a headache, obviously. And then severe neurodeficits can occur as well. And they need to go for a CAT scan. And then with intracerebral, this is usually due to increased intracranial pressure, a blow to the head, a small artery burst, like an AVM. That stands for arterial venous malformation. Sometimes people are born with these, and they're very weak. So over time, it could burst, okay? So the aneurysm could burst. So that's just a comparison of 3 different types of brain bleeds. Subarachnoid hemorrhage can happen for a few different reasons. It could be due to an arterial aneurysm or an arterial venous malformation. Occasionally, it could be due to trauma. It could be due to like really high blood pressure and somebody has an AVM and it just bursts. Typically, patients present with the worst headache of their life and meningeal signs. And the reason they have the meningeal signs is the subarachnoid space is where the cerebral spinal fluid is housed. So when somebody has blood where it's not supposed to be in the brain, they're going to get meningeal irritation. So they'll have stiff neck, nuchal rigidity, headaches, photophobia, seizures, and nausea and vomiting. Anybody with a subarachnoid hemorrhage is going to be at risk for rebleeding 7 to 10 days after the bleed. So you need to keep them quiet. They're going to be at risk for increased intracranial pressure. So we'll be learning about those interventions. So you're going to make sure the patient is in a nice, quiet room. For subarachnoid hemorrhage, we're going to do all the interventions that result. You want to make sure that you're doing all the interventions to prevent increased intracranial pressure, and that to prevent rebleed, the patient is on nimodipine, which is a calcium channel blocker, which helps prevent rebleed of the subarachnoid hemorrhage, because calcium channel blockers result in smooth muscle relaxation and vasodilation, and the rebleed is usually due to a vasospasm. The warning signs after a head injury, we're looking for increased intracranial pressure. Even somebody that has a concussion, so they have a Glasgow Coma scale of 13 to 15, you're going to warn the family about these type of signs and symptoms so they can bring the patient back to the ED if necessary. People with moderate TBIs have a Glasgow Coma scale of 9 to 12, and severe is 8 or less. So with that being said, we're looking for increased intracranial pressure. So the first sign of increased intracranial pressure is a change in their LOC. Maybe they're becoming disgruntled. Maybe they have apathy. Something that there's a change in their LOC. Usually it's drowsiness, confusion, and they're difficult to arouse. So you want to catch that early. Pupils is a little bit later. So they may be slow to react or unequal, or you may have that dilated pupil on the ipsilateral side of the brain injury. They could complain of double vision. Maybe their extraocular movements are not moving, so you would check that. They're at risk for seizures, and we're going to check for bleeding or drainage from the nose and ears because they could have had a basilar skull fracture. Check for slurred speech, projectile vomiting. That's a sign of increased intracranial pressure. Preventing increased intracranial pressure, you're going to use these interventions on anybody that's at risk for increased intracranial pressure. For example, like somebody with a traumatic brain injury, somebody with a stroke, somebody with meningitis. We want to prevent increased intracranial pressure. There's a lot of reasons somebody could be at risk for it, right? So everybody that is at risk needs to be taking a stool softener because you don't want them to strain when they have stool, okay? And then you want a quiet environment. You want to dim the lights in the environment because they could be photophobic. You want to reduce fever with acetaminophen because the temperature is going to worsen intracranial pressure. It's going to increase intracranial pressure. Avoid flexion. Avoid hip and neck flexion. Don't let them use a pillow. Maintain normal body temperature. No coughing or sneezing. Make sure you're giving them antiemetics because you don't want them to vomit and strain. Head and bed needs to be 30 and the neck needs to be in a neutral position. Keep the room dark. Make sure you're giving oxygen to keep the PaO2 over 60 because hypoxemia, hyperthermia, and a low blood pressure are going to increase intracranial pressure. I talked about increased intracranial pressure in the A&P and assessment lecture for neurological function, but the normal intracranial pressure should be 10 to 15 millimeters of mercury. It's measured by an external ventricular drain. I don't expect you to know how to operate it. I'm just pointing out if somebody does have this, they're going to be at risk for meningitis. Anybody that has drains in their brain or has an open TBI or basilar skull fracture, they're going to be at risk for meningitis as well. Okay, recognizing cues of increased intracranial pressure. Your patient's going to have the first sign, a change in their LOC. They're going to be irritable. They could be. They could have restlessness. They could become very lethargic and have decreasing level of consciousness. That's usually the first sign. They could complain of a headache. They could have projectile vomiting and nausea. They could have a change in their speech patterns or they become aphasic. Pupil changes. We talked about that ipsilateral dilation of the pupil on the same side as the head injury. So ipsilateral. Cranial nerve dysfunction. So be looking for cranial nerve dysfunction. They could have ataxia, which is uncoordinated walking. They could have seizures, which is a late sign, and also Cushing's triad and posturing are late signs. Cushing's triad is bradycardia, increasing systolic blood pressure, so there's a widened pulse pressure, and a change in respiratory pattern. In posturing, I went over in the assessment lecture with the A&P. This is just a picture showing you what I just talked about the signs and symptoms of increased intracranial pressure. Make sure you can distinguish early signs from late signs. Again, a late sign of increased intracranial pressure is Cushing's triad. Increased systolic blood pressure, decreased pulse or bradycardia, widened pulse pressure, and change in the respiratory status or pattern, and also decreased respirations. Shock, on the other hand, and this is septic shock, hypovolemic shock, they're going to have a low blood pressure, increased pulse, so tachycardia, and increased respirations, so tachypnea. Neurogenic shock is the shock that presents with bradycardia, and we'll be talking about that when we talk about spinal cord injury. To prevent increased intracranial pressure, whether it's from a traumatic brain injury or a patient had a stroke in the first 72 hours, they're going to be at risk of increased intracranial pressure, or your patient has meningitis. These are all the interventions we do to prevent increased intracranial pressure. So we keep the head of bed 30, and this helps drain vascular volume from the head into the neck and into the superior vena cava. Stool softeners prevent patients from bearing down, having a bowel movement, which will increase intracranial pressure. You want to make sure there is no hip or neck flexion. In other words, you don't want them to flex their muscles because that's going to increase intracranial pressure. You may have to take the pillow off of the bed. so that their neck is not flexed. You want them in a private room. You want to reduce environmental stimuli because that's going to increase intracranial pressure. So in other words, only let one or two people in the room at a time, like family members. Don't let a whole group of people in the room. You want to dim the lights. You don't want it pitch black, but you want the lights turned down. Do not cluster your nursing care, which is what we love to do, because the longer you're in the room providing care, there's an increased chance of them getting increased intracranial pressure. You want to keep the O2 sat 94%. You want to treat hyperpyrexia or hyperthermia right away. So in other words, don't let them get a temperature. Give them acetaminophen. Hypoxemia, hyperthermia or temperature, and hyperacidemia. So say the patient is not breathing well and they're going to have respiratory acidosis. That's going to increase intracranial pressure. Mocamol is a mnemonic for the treatment of increased intracranial pressure. So obviously you would monitor it. Patient's probably going to be in the neuro ICU. They get osmotic diuretics, and the most popular one is mannitol, and I'll talk about that in a little bit. They could also get hypertonic fluid, like 10% dextrose, because remember, hypertonic fluid is going to pull fluid from intracellularly to the vascular system. Okay, so you would watch for pulmonary edema, fluid overload to begin with, and then they'll start diuresing. Corticosteroids are used for like brain, if the increased intracranial pressure is for anything but TBI. TBI steroids are not used anymore. Patients are going to be hyperventilated after the first 24 hours if they're vented. The reason is when you hyperventilate somebody, remember they're going to breathe off a lot of CO2, so they'll make them alkalotic. And you want them to be alkalotic because having a PaCO2 too high is going to dilate the vessels in their brain and add to the increased intracranial pressure. All right. Antipyretics, I talked about not letting them have a fever. You want to correct that right away. Muscle relaxants, like we used to give a lot of phenobarbital to patients with TBIs when they were on the vent to kind of cool them off a little bit, so to speak, let their brain rest. Oxygen, and you want to maintain the PaCO2 30 to 35 because acidosis, respiratory acidosis, is going to vasodilate the vessels in the brain, and that's going to increase intracranial pressure further. Hydrocephalus means water on the brain. So basically, there's excessive cerebral spinal fluid in the ventricles of the brain. And so this can happen due to like somebody had a craniotomy and there was like blockage of CSF flow, or there's overproduction of it for whatever reason, impaired production of it. Those are the reasons hydrocephalus can happen. The treatment for hydrocephalus is to put in a ventricular peritoneal shunt, and it drains the CSF from the brain. It's usually put in the lateral ventricle of the brain to the peritoneal cavity, and it's just absorbed by the body. Now, which is good that they have this treatment, but the problem is it puts them at risk for meningitis and infection. So you have to watch out for meningitis.